There are two conditions that doctors are told to look out for if they want to prevent diabetes in their patients. One is the metabolic syndrome, which involves a few things such as abnormal blood fats, a larger than advisable waist circumference and high blood pressure. It also puts you at risk of a heart attack and stroke. The second condition is much simpler and involves a high blood sugar and signs in the blood that your sugar has been high for a while. It's called pre-diabetes because it's thought to lead to diabetes unless you do something about it. But recent research suggests that in some people, pre-diabetes isn't pre-diabetes at all. Liz Selvin is Professor of Epidemiology at Johns Hopkins Bloomberg School of Public Health.
The metabolic syndrome is really a cluster of risk factors, whereas prediabetes is defined solely on the basis of hyperglycemia. So it's really a categorization of people who are not yet diabetic. They don't quite meet the criteria for diabetes. They're just below that criteria, but they might be at risk for the development of diabetes.
And so the criteria are your blood sugar level when you're fasting and something called your HbA1c or glycated hemoglobin, which is a measure of your blood glucose control over the last 3 months.
Exactly, correct.
And I think it's the same in America as it is in Australia. If you've got a HbA1c over 6.5% and a fasting blood sugar over 7, then that's classified as diabetes.
Correct. That's the same in the US and Australia.
So before you did the study, what evidence was there, because you're looking at whether or not the term prediabetes deserves the term prediabetes, what did we know about the track from a high fasting blood sugar that didn't qualify as diabetes or a high average HbA1c?
We have quite a bit of data on prediabetes in middle-aged adults, and work from our group and other groups have shown that prediabetes in middle-aged is a pretty good predictor if you're going to develop diabetes, and it's also related to other outcomes like the development of heart disease, the development of kidney disease, and death. So in middle-age, prediabetes is a high-risk condition, and there's also randomized clinical trials that show in middle-aged adults that if you lower blood glucose in people with prediabetes, that can prevent the progression to diabetes. So the fundamental thing is that we really have a lot of evidence in middle-aged adults, but very little evidence in older adults, which was part of the impetus for our research.
So what did you do in this study?
We followed older adults who had prediabetes and looked at who developed diabetes. And these participants attended a clinic visit when they were 71 to 90 years of age, a general community-based sample. And then we followed them over time to see who died, who was hospitalized, many other outcomes. And then they came back for a second clinic visit 6 years later, where we remeasured their glucose and all the other parameters to see who developed diabetes among those people who were pre-diabetes initially.
Okay, so you measured all these factors, particularly their fasting blood sugar and their HbA1c. So you had a group within that group who had what would be classified as pre-diabetes. And just for the sake of the audience, in case they know blood sugar levels, that's a blood sugar level between 5.6 and, say, 6.9 millimoles, which is a different measure from the one you use, and an HbA1c between 5.7% and 6.4%. So you had a group that were classified as pre-diabetic. What happened to them?
We found that at the initial study visit, prediabetes was very common. Depending on which definition you used, 25% to 75% of people of this older adult population would be classified as having prediabetes. But then when we looked to see what happened to those people over time, we found that that category of prediabetes wasn't very prognostic in this population, meaning that very few people in this group went on to develop diabetes. So many more people who were initially pre-diabetic actually died or returned to normal glucose levels. That was actually the most common outcome, was that people with prediabetes actually returned to normal glucose by the time of the 6-year follow-up visit. So only 10% of those people with prediabetes developed diabetes, whereas 40% returned to normal glucose levels.
And did they have any special intervention along the way that might have differentiated them?
No. So this is just a community-based, free-living group of individuals, so no intervention whatsoever. We're just watching them to see what happens over time.
So it wasn't a good predictor of type 2 diabetes if you were over 70. Why would it be different from middle age?
I think we know that diabetes is a very heterogeneous condition.
What does that actually mean, heterogeneous?
Well, there's certainly different underlying causes for diabetes, and that I think in younger individuals, we see a much more severe condition. It often is very hereditary. Family history becomes very important for younger onset type 2 diabetes, meaning in middle-aged. And those people have very severe outcomes and are a very high-risk group. Whereas in older adults, I think we're actually seeing a different underlying pathophysiology. We're seeing that the pancreas is just not functioning as well as it used to. It's producing less insulin. We're seeing some cells that are resistant to the effects of insulin that's just occurring as people age. And it's literally not the same underlying physiology. It's not the same diabetes that we see in middle-aged adults.
So the thing that confuses me slightly about this study is you had a very high proportion with pre-diabetes going in. A high proportion reverted to that they wouldn't have qualified as pre-diabetic. Why did you have such a high proportion to begin with, and presumably a lower proportion 5 years in? Surely the proportion should have stayed about the same. Did you have new people developing high fasting blood sugars?
So we're seeing a lot of switching over, right? That it's not this stable condition, I think is what you're describing. So is that a lot of people with prediabetes at the first visit, lots of people with prediabetes at the follow-up visit, not necessarily the same people. They're moving across these categories. It's not this stable diagnosis, so to speak.
So the good news there is that it could be tractable to change.
Absolutely. I think that's absolutely the case. We know that lifestyle changes and eating healthy, even modest weight loss, can lower your glucose levels. So I think that's very much the good news, that lifestyle modifications, eating healthy, losing weight, those are things that can really help from a metabolic standpoint.
Now, there's a bit of an epidemic of general practitioners, primary care physicians doing fasting blood sugars and HbA1cs. They're encouraged to do so because they say that type 2 diabetes is underdiagnosed in the community. But in fact, from this study, in a 70-year-old, you could be overdiagnosing and getting over-concerned. Is there a case still to check fasting blood sugars if you're over 70?
I think monitoring is good, but I think what we see is that this category of prediabetes, it should not be a priority in much older adults. I think, the priority should be other comorbidities, other major risk factors for mortality, things that are affecting quality of life. And that, sort of a slightly elevated glucose level is simply not a priority for most older adults.
Whereas you might look for it more closely in somebody who's 45 or 55.
Exactly.
And where does this leave the metabolic syndrome? So just to explain, this is where you've got abnormal blood fats, your triglycerides are high, your HDL is low, you've got a fat tummy, your blood pressure is up, and you're fasting and you're tending towards prediabetes. Where does it leave the metabolic syndrome?
We didn't specifically look at metabolic syndrome in older adults, but I think it's the same kind of clustering of risk factors that probably have a lot more meaning in middle-aged. And in older adults, we're much more focused on underlying comorbidities, whether you have a history of cardiovascular disease, whether you have hypertension, whether you have major underlying comorbidities, physical dysfunction. I think this research really emphasizes that we should be focusing on those underlying conditions rather than just mildly elevated glucose levels in isolation.
It's old-fashioned, but focus on the whole person.
Exactly. I think that's absolutely correct.
Liz Selvin, thank you very much for joining us.
Thank you so much for having me. This was wonderful.
Liz Selvin is Professor